Hello everyone. Let us now start the discussion of selected pediatric infections, and the first infection we shall be taking up is measles. Measles is a high yielding topic for your NEET super specialty as well as fellowship entrance exam. So let us discuss measles including the latest aspects given in Nelson 21st edition. Measles is a viral infection predominantly seen in children. The measles virus is also called as rubeola virus. It is different from rubella, so measles and rubeola are the same entity. What is the etiological agent? It is caused by, the measles infection is caused by measles virus which belongs to the family Paramyxo. So it belongs to Paramyxovirus family and the genus here is Morbillivirus. Measles virus is a single-stranded RNA virus which has an envelope. So it is considered to be an enveloped single-stranded RNA virus. What is the mode of infection? The mode of infection mainly occurs, the person-to-person contact occurs through droplet route. Droplet route is the source of infection. Remember that droplet route is the source of infection only through cases of measles, because potential MCQ point, there is no carrier state of measles. So among the pediatric infections, measles is one prominent infection where there is no carrier state, potential MCQ for your entrance exam. The third thing that we need to know is it is a highly infectious condition with the secondary attack rate mentioned in standard books ranging from 80 to 95%. So it has a high secondary attack rate. So it is a highly infectious condition. And the fourth thing is period of infectivity. The period of infectivity in measles virus ranges from 4 days before to 5 to 6 days after the onset of rash. The period of maximal infectivity is defined according to the rash. So 4 days before to 5 to 6 days after onset of rash is the period of infectivity in case of measles. Let us discuss a MCQ based point which is given in Nelson 21st edition. The MCQ based point talks about two important structural proteins of measles which are involved in induction of immune response. You need to know that measles surface has 6 important antigenic proteins. Out of these 6 antigenic proteins, there are 2 proteins which have a role in immune response of the host, and thus it plays a role in protecting a patient from measles infection. The first protein, the first antigen on the measles virus is the heme agglutinin protein, also called as H protein, and the second is the fusion protein or F protein. What is their importance? Hemagglutinin protein, the antibodies against this are involved in neutralization of the virus. So neutralizing antibodies are formed against H protein, whereas the proliferation of virus is limited inside the tissues by antibodies against fusion F protein. So the neutralization of virus, including those in culture media, remember it is the H protein antibodies, and antibodies against F protein are involved in stopping the proliferation inside the tissues of host cells. So these are the 2 proteins involved in immune response to measles virus. Now what is the pathology of infection? Once measles enters through the droplet route, what are the pathological features it produces? It causes infection of both the respiratory tract as well as the non-respiratory tissues. Among non-respiratory tissues, it has a special propensity to involve initially the lymphocytes or the circulating immune cells. Among respiratory tract, once it causes infection, it causes necrosis and inflammation of the respiratory tract epithelium along with the lymphocytic infiltrate. Just like any other virus produces a predominant lymphocytic infiltrate. It also produces a small vessel vasculitis like presentation, and the pathological hallmark of infection are multinucleate giant cells. Measles infection produces multinucleate giant cells in the tissues. These multinucleate giant cells are also called as Warthin Finkelday cells. They are full of intranuclear as well as intracytoplasmic inclusions which are filled with proliferating measles virus. So the hallmark of infection, if MCQ asks, they are multinucleate giant cells called as Warthin-Finkeldy cells. Now another high yield point. There are two types of receptors which are present on the measles cells. One is CD150 and second is PVRL4, also called as Nectin-4. CD150 is the receptor which is present. It is the receptor for measles virus present on non-pulmonary tissues. Example, lymphocytes, alveolar macrophages which are not a part of the pulmonary tissue, and in some unfortunate cases CNS as well. Whereas PVRL4 or Nectin-4 is considered to be the receptor for measles. So measles virus enters cells through this receptor in respiratory epithelial cells. So if question asks about respiratory epithelial cell, this is your answer, and if question asks non-pulmonary tissue, this will be your answer. So these are the two type of receptors for measles present on the human cells. Now let's talk about some terms which are asked in exams regarding measles infection. First is the incubation period. One liner, the incubation period of measles is 10 to 14 days. Second thing is a term called as modified measles. Modified measles is a mild infection. There is virtually no complication and a self-limited natural history is seen. It is seen in individuals who already have pre-existing partial immunity to measles. So either due to active or passive immunization, if there is immunity and measles virus does cause the infection, it produces a mild infection. We call it as modified measles. So remember, it is a mild infection and there are no complications which are seen. Then there is term called as measles in pregnancy. Remember that measles can cause infection in pregnancy, but there is no congenital abnormalities produced. So it is a non-teratogenic infection. However, measles in pregnancy can be more severe as compared to a non-pregnant female, and the risk of abortions can always be there. Then measles shows a cyclic trend. Epidemiological studies show that infections of measles in community increase every 2 to 3 years. Yet to be defined cyclic phenomena and genetic reassortments have been proposed in producing this phenomena. Exact reason for this is not known. And that is why every 2 to 3 years it is seen that in endemic areas and in partially immunized population, which includes certain parts of India, there is a resurgence of measles every 2 to 3 years. And finally, there is a WHO strategy for measles elimination. The strategy is called as catch up, keep up, follow up therapy. Catch up means all children who are yet to be immunized for measles, they need to be caught up, they need to be immunized. Keep up means keeping up with the immune status, keeping up with the nutrition status, keeping up with the immunization status of measles vaccination. And follow up means you need to follow up for any outbreak occurring in the community. So catch up, keep up, follow up. Just remember, this term has been used specifically for measles elimination in WHO programs. Now coming to the clinical features of measles, we have already said that the incubation period is 10 to 14 days, right? So initially, the first thing to occur in measles is always fever. So day one means the day infection begins, there will be onset of fever along with prodromal symptoms. So fever is usually the presenting feature along with prodromal symptoms. How would you remember the prodromal symptoms? Remember, 3 C's are seen in prodromal symptoms. What are these 3 C's? There is cough, there is coryza, and there is conjunctivitis. All the 3 tend to occur and they appear before onset of rash. So fever with prodrome is the first feature of measles infection in children. If question asks you which is the most consistent feature of prodrome syndrome among these 3 C's, it is the conjunctivitis which is the most consistent. Some of the microbiology textbooks say it is seen in as high as 90 to 95% cases of measles infection. Now on day 1, this is the syndrome which is produced, fever with prodromal symptoms. After this, between day 2 to day 3, there is occurrence of enantheme. You know what is exantheme? Exantheme is a rash occurring on the skin. Enantheme is a eruption occurring on the mucous membrane. So enantheme occurs. The typical enantheme seen in measles is called as Koplik spots. What are Koplik spots? They are grain-like lesions with a surrounding erythema seen on the buccal mucosa. If I have to show you a picture, this is a typical picture showing presence of Koplik spots. The description given in textbook says Koplik spots are bluish white lesions resembling grains of sand with surrounding erythema. So there is a surrounding redness which is present in these lesions with surrounding erythema. So bluish white lesions with surrounding erythema occurring on the buccal mucosa are known as Koplik spot. They occur second or third day. MCQs are often asked on Koplik spot. They can show you a picture, they can give you a clinical case, or they can ask you what is true regarding Koplik spots. Koplik spots, there are 2 or 3 things you should know. Koplik spots commonly occur on the buccal mucosa. What is the most common site on buccal mucosa? They commonly occur in front of lower second molars. Lower second molar is the first site where they first appear. Later on they spread and can occur elsewhere in the buccal mucosa as well. And even on the lip and tongues. Although lip and tongue involvement is relatively rare in case of recent days when you see measles infection, many of the children who get a measles infection, they have a modified measles rather than a true measles. And so Koplik spots occurrence is also showing a slight deviation if you go by what dermatology textbooks say. So these are the established things that enantheme known as Koplik spot will occur on this day. And after this, around day 4, there will be onset of rash. The rash seen in these children is a erythematous, that is red colored maculopapular rash. There are no vesicles, no fluid filled lesions. So erythematous maculopapular rash. Where does the rash begin? It follows a very typical course. It first appears on the face and behind the ear. On the face, it will appear on the forehead. Mainly it is seen on the forehead, and it will appear behind the ear. Then it will spread to the trunk, and then it will spread to the limbs. And then after the rash has come, it will disappear in 7 to 8 days or about 1 week, leaving behind pigmentation. So there is a post-rash hyperpigmentation. There is a post-rash hyperpigmentation. We call it as brownish colored or brownish, B-R-A-W-N-I-S-H, brownish kind of hyperpigmentation which is seen after measles rash goes away. So this is a child showing diffuse maculopapular rash first appearing on the face and later on spreading to the whole body. So this is the typical appearance, typical course of a measles infection. This is the one you are supposed to remember. You know it already, all of you are pediatricians, but I have just summarized at one place the things which are important and can be asked in MCQ entrance in clinical scenarios. So what are the complications in measles? Now measles virus is associated with a lot of complications. The most common complication of measles virus is acute otitis media. The most severe complication but rare and occurs many years later is a complication called as SSPE. SSPE stands for subacute sclerosing panencephalitis. More about this we will talk in some time. We will discuss this in details. This is a hot topic for your NEET super speciality 2021, 22, 23, all the 3 exams. Then what is the most common cause of death in measles? The most common cause of death in measles, all of these are MCQ one-liners. The most common cause of death in measles is pneumonias. Now the interesting thing regarding pneumonia in measles is, pneumonia in measles is of two types. It can be primary measles pneumonia. Virus itself is causing pneumonia. We call it as primary measles pneumonia. There are many names for this. It is also called as primary giant cell pneumonia because giant cells are present. It is also called as Hackett's pneumonia. And the second is pneumonia secondary to bacterial infections. We know that measles produces a partially immunosuppressive state because it involves the lymphoid cells, and so there is an increased risk of bacterial infections in case of measles. So bacterial infections which can cause pneumonia in measles, they include pneumococcus as well as Haemophilus influenzae. And if MCQ does ask you among them which is more common, remember that secondary pneumonias are more common than primary pneumonia in case of children with measles. So as a complication, this is the cause of death in case of measles. Other than this, the other common complications which you need to remember, they include myocarditis, encephalitis. There is a term called as black measles, also known as hemorrhagic measles, where there are erythematous, hemorrhagic, reddish to black bullae form on the skin. And black measles fortunately is less commonly seen these days, but it used to be a fairly common complication in the pre-vaccination era, and that too in children who were severely malnourished. Black measles carries a fatality rate as high as 90 to 95%. Nelson also says the same thing. It is universally fatal once it develops, but fortunately it is very rarely seen these days. And finally, there is another complication of measles called as diarrhea. Diarrhea is also common in case of measles. An important thing to remember in case of measles, that measles complication rate is increased in children who are having protein energy malnutrition and those who are having vitamin A deficiency. That is why vitamin A supplementation and managing the calorie and protein content in a child with measles is of paramount importance. So it is like a vicious cycle. A malnourished child is more prone to measles, and if a child with measles gets further complications, those complications can be life-threatening because it is a malnourished child. So this complication rate is a problematic thing, and that accounts for why the measles virus infection has high mortality. Now coming to measles virus, it induces immunosuppression. The question is how? The measles virus induces immunosuppression by two mechanisms. First, it causes infection of the CD4 plus T cells, which suppresses helper immune T cell 1, that is Th1 immune response. And secondly, it causes infection of alveolar macrophages, dendritic cells and circulating lymphocytes via entry using CD150 receptor. The combination of the two produces a state where there is increased risk of secondary infections, particularly pneumonias. So this is something which is mentioned in Nelson, more elaborated in Nelson than before, and so need to be remembered separately. Now coming to the diagnosis and treatment of measles, the diagnostic modality commonly used is serum immunoglobulin M antibody. You can test in the serum. It is positive in case of measles infection. You can also do a IgG antibody titers, four-fold rise at a gap of 2 to 4 weeks. At second week, it will be acute infection. Around fourth week, it would be more of a convalescent phase. So 2 week ke gap pe if you do titers and if there is a four-fold rise in IgG antibody, retrospectively tells you that measles was the infection. And of course, virus isolation and PCR can theoretically be done. They are not available at many of the centers in India. except for higher tertiary care centers. Now coming to the therapy of measles. Therapy in measles is mostly supportive. You need to look at the nutrition status, you need to ensure hydration, and in case of any complication, you need to manage that. And of course, obviously, you will use antipyretics for the fever which is happening. Skin rash which is happening, there is nothing you can do much about it. It comes and goes away by itself. Post-inflammatory hyperpigmentation, again, nothing much you can do about it. If question says, is there any agent which is active in vitro against measles? The answer is ribavirin. Ribavirin is an antiviral agent. Commonly you have read it is effective against RSV infection. Ribavirin has been found to be effective in measles infection, effective against measles in vitro conditions. However, it is not FDA approved for use in case of children. So if question asks you which is useful, the answer is ribavirin. Is it used clinically? The answer is not. It is more of a theoretical thing, again mentioned in Nelson 21st edition. And finally, before we go to a special topic, Nelson says, vitamin A therapy is indicated for all patients with measles. Right? I told you, vitamin A deficiency increases the risk of measles and vice versa. Vitamin A should be administered once daily for 2 days. This is important. 2 consecutive days. At the doses you already know, more than 2 years it will be 2 lakh international unit, 6 months to 1 year it will be 1 lakh international unit, and less than 6 months it will be 50,000 international unit. The only difference is 2 consecutive days you will use it. And in case the child is already having night blindness or similar symptoms related to vitamin A deficiency, then after this regime, you will repeat it after around 2 weeks. So this is vitamin A therapy. So vitamin A therapy is mandatory and you have to give for 2 days instead of a single time therapy. How can you prevent measles infection? Use of measles specific vaccination. Now MMR vaccine details have been discussed in the vaccine module, so I am not going into details here. For post-exposure prophylaxis, you have 2 options. You can either use measles vaccine or you can use measles specific immunoglobulins. Measles vaccine is standalone, no longer available, so we synonymously used with MR vaccine. In private setup, MMR comes. In government setup, you have measles and rubella, which comes as the vaccine. So measles vaccine, if there is an unimmunized patient or a pregnant female or a less than 6-month child and he had exposure or contact with a known measles patient, how will you prevent measles from happening in that person? You will give measles vaccine. Measles vaccine is effective if given within 24 to 72 hours after exposure. Whereas measles specific immunoglobulin are effective if given intramuscularly in a dose of 0.5 ml per kg up to 6 to 7 days after exposure. It is a passive immunization method. And when will you give measles specific immunoglobulin? Measles specific immunoglobulin are indicated in high risk individuals like pregnant females, people who are immunosuppressed or immunocompromised, and children less than 6 months of age. And that too only when there is contact with a measles case. There are no subclinical cases or carrier states in case of measles. So this finishes initially the measles infection. Now we move to the extra edge topic on which difficult questions are being asked, and so we'll discuss in details SSPE. As I just said, SSPE is a rare, chronic but fatal complication of measles infection. SSPE is a rare chronic progressive demyelinating disease caused by measles virus. Harrison 20th edition says 85% of these children are between 5 to 15 years of age, and MCQ on this has been asked in NEET PG exam, not in super specialty, NEET PG. But you know that NEET PG questions sometimes can be asked in super specialty as well. So the most common age group is 5 to 15 year for SSPE. What is the timeline for the development of SSPE? Nelson as well as Harrison, both of them say that cases of SSPE present as late as 7 to 13 years after measles infection. And so many times the measles history may not be there. So that is why you need to go back into time and ask the complete details if you have a SSPE suspected patient. And once the onset begins, then it is universally fatal in 1 to 3 years. It has a very high mortality. Western textbooks say that with the newer regimes, the mortality rate has fallen a bit, but in a Indian setting, what we see is most of these patients usually succumb to the illness. Now coming to the stages of SSPE. SSPE is divided into 4 stages with the corresponding clinical feature. In stage 1, you have subtle behavioral changes. So subtle behavioral changes are seen in stage 1. Stage 2, there will be onset of myoclonic jerks. Stage 3, you will have child developing involuntary movements, that is choreoathetoid movements. These children will also develop rigidity and they will have progressive fall in sensorium. And stage 4, the patient reaches a vegetative state where there is failure of vital centers of the body, and this is the stage during which death occurs. Vital centers of the brain, they tend to fail, and coma also develops in stage 4. So these are the 4 stages of SSPE which are defined. Now, to diagnose SSPE, we follow a criteria called as Dykens modified criteria, not given in Nelson 21st edition but asked in entrance exam. So you can add it to your notes. Dykens modified criteria. There is a major criteria and there is a minor criteria. The major criteria are 2. One is appropriate clinical history of measles and second is elevated CSF antibody against measles. So CSF, not blood, CSF should have measles specific antibody, that is a major criteria. Minor criteria include EEG changes suggestive of SSPE, which we shall see, increased CSF immunoglobulin, brain biopsy, and special molecular test to identify measles virus mutated genome. How do you say it is SSPE? When there are 2 major plus 1 minor criteria, it is diagnostic of SSPE in the patient. So this is something you need to remember, add to your notes. And this is how the EEG of SSPE looks like. EEG of SSPE is characterized by the presence of classical Radermacher complexes. What are Radermacher complexes? They are high voltage, repetitive, polyspike, sharp and slow wave complexes. As you can see here, these are the polyspike pattern which is happening. These polyspikes are occurring at a gap of every 4 to 16 seconds. So there is a gap of 4 to 16 seconds, then another Radermacher complex happens. And during each period, frequency will be 0.5 to 3 Hz. These are called as Radermacher complexes. And they are considered to be diagnostic of SSPE in clinical setting. However, if you go by the ideal Dykes criteria, it says very clearly that Radermacher complex is only a minor criteria and so it is not diagnostic if you go strictly according to the criteria. Now coming to the management of SSPE. The management of SSPE is problematic for the patients who are having myoclonic jerks. You can give drugs like carbamazepine or oxcarbazepine. Now the interesting thing here is the traditional teaching is carbamazepine worsens and is contraindicated in myoclonic epilepsies, right? But in SSPE, it is the most effective agent in controlling the myoclonic jerks. And what is the new treatment regime now available for SSPE? The new treatment regime available for SSPE comprises combination of isoprenosine along with intrathecal, that is inside the CNS you give injection of interferon alpha. It has been shown to increase the survivability and neurological outcome in the child. However, the improvement seen generally is only by a few years. Eventually, SSPE carries a very high mortality. And if you remember this person, if you know this person, if you don't know this person, absolutely fine. But if you know this person, you would know that he is Dr. Gregory House. The House series, which has been a very popular series for all medical students and non-medical students alike. In season 1, episode 2, in case you want to go to Amazon Prime and want to see it, season 1, episode 2, the case discussed was a case of SSPE. The child presented behavioral changes, moving to myoclonic jerks, and eventually the patient was diagnosed with SSPE, where the history had been missed. And this was the person who made the diagnosis there. If you look at the TV series, they said very clearly that the patient is being given interferon alpha and the patient will improve. However, that is far from truth. SSPE still carries significant mortality and morbidity. So whenever you are feeling bored discussing all these diseases for super specialty, take out time, watch that series and come back to the discussion. You will always have a better understanding. It will form better conjunctions in your brain. So this finishes our discussion of SSPE. The next infection we shall be discussing is rubella. Rubella is also called as German measles. First of all, the etiological agent. Rubella is caused by a single-stranded RNA virus belonging to the family Togaviridae. So it is also called as a Toga virus, and it belongs to a genus called as rubivirus. So rubivirus is the genus of this particular pathogen. Mode of infection, it is spread through droplet route. So respiratory secretions are the predominant mode of transmission of rubella from person to person. Incubation period is between 14 to 21 days as given in standard textbooks. And if you are asked period of infectivity, it is 5 days before to 6 days after the onset of rash. So just like other viral illnesses, we take rash as to be the central point around which we define infectivity. 5 days before to 6 days after the onset of rash is the maximum period of infectivity. Now, what are the clinical features of rubella? Now, you need to understand that rubella is a milder illness as compared to measles and even chickenpox when it comes to fever and rash prodromes. So, what happens is, initially on day 1, there is occurrence of prodrome symptoms along with low grade fever. The fever is so low grade that it may even be missed by some of the parents, and sometimes fever is actually not very prominent. The prodrome is very different from what you see in patients with measles. In measles, you have cough, coryza and conjunctivitis. Here you find that there is irritability, some dry cough, but little to no conjunctivitis. So, no conjunctivitis is seen in these patients. This prodrome continues for approximately 2 to 3 days. 3 days later, that is day 3 or day 4. So, you can write 2 to 3 days later, there is onset of rash. The rash is in the form of pink colored macules. So, fine pink macular rash is the predominant rash seen in rubella. It appears on face and trunk and later on spreads to limbs. The important thing to understand here is, as rash spreads peripherally, the facial rash disappears. The facial rash will disappear. So, at no point of time, the entire body is involved in a rash. So, it was one of the old MCQ point also, that which of the following is a childhood rash where the whole body is never together involved? The answer is rubella. So, it keeps, as it spreads from face to the extremities, the rash tends to disappear from the original part. and this is the typical face which has been shown. It appears on neck and face, then it goes to trunk, and then eventually the limbs are involved. Usually does not occur on palms and soles, and rash tends to disappear at each site within 3 days. So coming in 3 days after prodrome and disappearing also in 3 days, that is why rubella is also sometimes called as 3-day measles. So one alternative old name of rubella is 3-day measles. So these are the typical clinical features what you find in patients with rubella. In addition to the clinical features which I described, there are 3 things which are important, or 3 characteristic features which are clue for underlying rubella, which will be mentioned in the clinical MCQ in super specialty as well. The first characteristic feature is lymphadenopathy. Lymphadenopathy in rubella is characteristic. It appears behind the ear, that is retroauricular. There is posterior occipital and anterior cervical lymphadenopathy, and usually tends to appear along with fever. This type of localized lymphadenopathy is characteristic. Second, you find that there are lesions present on the soft palate. 2 types of lesions are described. First, you can find hemorrhages present on the soft palate. So hemorrhagic lesions will be present. And secondly, you may find pink colored macules. These pink macules are called as Forsheimer spots. So presence of either hemorrhagic lesions on soft palate, or Forsheimer spots on soft palate, or lymphadenopathy as described along with fever and rash, immediately your mind should go towards rubella as the likely possibility. Now moving to the complications of rubella. The rubella complications are mostly mild in nature as compared to other viral infections, and they comprise post-infectious thrombocytopenia, which lasts for around 2 weeks, and it is commonly seen in children who develop rubella. Then you have arthralgia and arthritis, which is more common in adolescents and adults as compared to children. In fact, more than 70 to 85% of post-childhood rubella is associated with arthralgia and arthritis. Again, it is self-limiting. And third, you have encephalitis. Encephalitis is a rare illness, but 2 types of encephalitis occur in rubella. One is a self-limited rubella encephalitis, which is mild in nature, and second is a progressive illness, what we call as PRP. It is called as progressive rubella panencephalitis. Progressive rubella panencephalitis is a severe illness which resembles SSPE and has a fatal outcome in 2 to 5 years. So within 2 to 5 years, the child expires. Fortunately, it is a very rare complication. So these are the complications of rubella. Now coming to management and prevention. Management in most patients is supportive. Isolation is needed for 7 days after the onset of rash. This is a MCQ point, so you can add it as a one-liner to remember. Rubella vaccine can prevent disease in non-immunized children if it is given within 3 days of the exposure. Now, how do you manage pregnant females who have been exposed to rubella? What we do is, we take blood and check for rubella-specific immunoglobulin, and this testing is done 3 times. One, at the time of exposure, we call it as baseline. Second, we do 2 to 3 weeks later, and then another one is done at 6 weeks. Some of the protocols say that you take 2 samples at baseline, followed by one at 2 to 3 weeks and one at 6 weeks. It means the same thing. If the baseline sample is positive for immunoglobulin, at the time of exposure, the patient has immunoglobulin G. It means the patient had been exposed prior, and so the female is immune in nature. The pregnancy can be continued normally. If the baseline sample was negative and the subsequent 2 samples come to be positive, then it shows that seroconversion has happened. That is, the patient was initially not immune to rubella, and later on IgG came, so exposure to rubella happened. They will require genetic counseling. You will counsel the female to undergo medical termination of pregnancy. If MTP is not possible, or if the mother is not willing for MTP, then you can give rubella specific immunoglobulin, explaining very clearly that giving immunoglobulin will not ensure that the child will not develop congenital rubella syndrome, the dreaded teratogenic syndrome. However, this is what the protocol says. Now, moving over to the next infection, that is varicella zoster virus infection. Etiological agent, it is caused by varicella virus, which is a double-stranded DNA virus belonging to the herpes virus family. Mode of infection, again, it is similar to the other viruses we have discussed. It mostly occurs through close contact, and respiratory infection or droplet route is the common mode of infection. The incubation period described in textbooks is 10 to 21 days. Usually 14 to 16 days, median value is taken. So, median value is approximately 14 to 16 days. However, if you asked a range in MCQ exam, this is what was asked in one of the older questions, the answer will be 10 to 21 days. And what is the maximum period of infectivity? The period of infectivity is 24 to 48 hours before rash till all the lesions have crusted. So, crusting of lesions denotes that the patient is no longer infective. These children who develop chickenpox, we do not allow them to go to school till their lesions have crusted. All the lesions have crusted and no new lesions are coming. There is a problem of latent infection in patients with varicella zoster virus. Latent infection can occur during the incubation period, or it can occur during the clinical disease. The virus is transported in a retrograde manner through sensory axons to the dorsal root ganglia and to the cranial nerve ganglia as well. Remember, virus lies and sleeps in the ganglionic neurons. It does not exist in non-ganglionic axons or neurons. Viremia can also contribute to latent infections. Later on, subsequent reinfection can cause herpes zoster in later life. Now, coming to the clinical features of varicella zoster virus, how chickenpox comes. After incubation period of 10 to 21 days, initially there is moderate grade fever, there is headache and anorexia, which is called as the prodromal symptoms. 24 to 48 hours later, there is onset of rash. Rash progresses in a very typical manner. There is initially a macule. In a few days, it turns into papule. Then it forms a fluid-filled lesion called vesicle, and eventually it heals by crusting. This is the typical example of how the lesions tend to appear. And the vesicles which are present, they are filled with a clear fluid with surrounding pink-red erythema. These vesicles, this description of vesicles given in textbooks is as dewdrops on rose petal appearance. गुलाब के पत्तों पर ओस की बूंदें. Hindi translation, literal translation. English translation, I have already written here. Dewdrops on rose petal appearance. Typically how older people in the 1800s and early 1900s, the rash of varicella chickenpox has been described. These days the studies are a bit more bland. Earlier the studies, although the means were limited, but even the explaining, treating physicians, pediatricians, they were a bit more poetic than what we have today. So, dewdrops on rose petal appearance, if you find the terminology, it is used for patients with chickenpox. Now, regarding the rash, this rash has certain characteristics, the key words which you need to identify in exam. First of all, it is a very itchy rash. So, it is a pruritic rash. Significant pruritus is present. Measles and rubella rash are usually non-pruritic, and so they were not mentioned. It is a very itchy rash. Secondly, it is a centripetal rash. Centripetal rash means it begins in the trunk, later spreads to face as well as spreads to limbs. So, starts from the center and spreads to the peripheries. And these lesions tend to occur in crops. A lot of lesions will occur on one day, in a limited area, then another region, one day later, another crop of lesion will appear. So it occurs in crops. And the same patient may have different lesions in different morphology. What it means is, suppose I am a child with chicken pox. Today I had macules, 8 or 10 macules occurring here. 3 days later, these macules will turn into papule. But now new crop of lesion will come here. Okay, this will be macular, this will be papular, then this will, another 1 or 2 days it will turn into vesicle, this will now turn into papule, another lesion, group of lesion will appear here or on the proximal limbs. So if you see on day 5 or day 6, I will have macules present here, papules present here and vesicles present here. So different type of lesion present in the same person is again a clinical clue for the child having varicella. And lastly, the rash tends to resolve, each group of vesicles tend to resolve with crusting, and crusting usually occurs between 3 to 7 days for each crop. And usually 2 to 3 crops come, and then around 7 days or so, 7 to 8 days we say, the chicken pox tends to settle down. Again, it is variable. Some children may show very mild 1 or 2 crops only, and some may have extensive rash occurring all over the body. The general rule is, younger the child, milder is the infection, older the child, more severe is the infection. And they usually do not heal with any pigmentation. Some post-inflammatory scars may be left. Scarring is more in adolescents and adults as compared to children. So you can just write as a point somewhere to remember that scars are more common in case of adults as compared to children. But overall, they are considered to be rare. Now, moving to the complications. One of the complications, the photograph is already mentioned. We'll come to this. First of all, the most common complication of chickenpox is secondary bacterial infections, mainly involving gram-positive bacteria like Staph aureus and Streptococcus pyogenes. CNS complications are also common. The common one among them is acute cerebellar ataxia, on which MCQ has been asked. They can also develop meningoencephalitis. Purpura fulminans can develop, in which large purpuric bullae are present over the body. It occurs due to antibody against protein C, which tends to form in certain individuals. And rarely stroke and Ray's syndrome can develop in these patients. Finally, latent infection and reactivation can cause herpes zoster. Herpes zoster is more common in adults as compared to children. The virus which had hidden in the ganglia sometimes gets activated due to stress, due to changes in the immune status, due to some drug being taken, some changes occurring in the environment of the patient. Many times no precipitating factor can be found. There is reactivation of the virus and it produces a dermatomal rash. This dermatomal rash, which is painful, it is described as a burning kind of pain and tends to heal with scarring, is seen with herpes zoster. Fortunately, herpes zoster responds to acyclovir, but unfortunately, herpes zoster has a tendency to recur after every few years. Again, it varies from person to person when it would recur. Treatment of chickenpox. Drug of choice where you need to give is acyclovir. However, acyclovir is not needed in most patients, as we shall see. The dose of acyclovir is 20 mg per kg per dose orally, given 4 times a day for 5 days, ideally started within 24 hours of the onset of rash. IV therapy is indicated for severe disease and for varicella occurring in immunocompromised patients. Acyclovir therapy is not recommended routinely by American Academy of Pediatrics in a otherwise healthy child. So, only in older children more than 12 years or pregnant females or people with immunosuppression, they are the ones where you will use acyclovir. Acyclovir resistant VZV is a problem in HIV positive individuals. There you need to use IV foscarnet, and if IV foscarnet fails, you need to go in for IV cidofovir. So in resistant patients, the sequence is acyclovir, foscarnet and cidofovir. Points to remember: in chickenpox, aspirin is contraindicated due to risk of Ray's syndrome. Ibuprofen is also contraindicated due to risk of necrotizing for fasciitis. It is a potential MCQ. So remember, any child who has varicella, you need to give any antipyretic for fever. Only paracetamol, that is acetaminophen, is indicated. Progressive varicella is seen in immunocompromised patients, pregnant females, and sometimes even normal people, including children, adolescents, and adults. Progressive varicella is associated with recurrent crops of new lesions, which are extensive in nature. Plus, there is onset of severe systemic involvement leading to encephalitis, myocarditis, and similar complications, and they usually have a high mortality. Fortunately, it is seen in less than 0.5% of the individuals. The next disease we will be discussing is fifth disease. Fifth disease is also called as erythema infectiosum. It is caused by a viral infection. The virus agent is human parvovirus B19. Human parvovirus B19, as you already know, it is a single-stranded small DNA virus. There are very few viruses which are single-stranded DNA, and parvovirus B19 is one of them. The most common age group for fifth disease is 5 to 15 years, whereas the incubation period for fifth disease is 16 to 17 days. Although it can be quite variable, ranging from as short as 1 week to as long as 28 days also. And the route of transmission is through the droplet route. So all of them are being spread through the respiratory secretions. Now, what are the clinical features? The clinical manifestation of this is very dramatic, very characteristic, and you may get a visual based upon this or a clinical plus visual combination in super specialty exam. Initially, after incubation period of 16 to 17 days, the first thing to develop is a prodrome. The prodrome comprises ill-defined low to moderate grade fever, along with other features like irritability and URI-like symptoms. There is no conjunctivitis here like measles. So, URI-like symptoms. After a variable period, which may range from 1 to 5 days, after a variable period of fever, there is onset of rash. And what is the classic rash? This is the classic rash. Look at this child. Can you see that there is bilateral macular or maculopapular erythema on both the cheeks? This type of appearance is called as slapped cheek appearance. So, the rash produces an appearance called as slapped cheek appearance. Potential MCQ, potential visual, very important. Slapped cheek appearance refers to bilateral maculopapular and sometimes only macular rash, maculopapular oblique macular you can write, appearing bilaterally on cheeks. Later on, it spreads to the trunk. When it spreads to trunk and proximal limbs, it has a very characteristic feature. It begins as macule. These macules show central clearing and they tend to develop a lacy or reticulated pattern. And this rash, once it develops, takes 1 to 3 weeks to resolve. This is the usual presentation of a patient with fifth disease. It is primarily a clinical diagnosis, although in sophisticated labs you may find specific tests being available. In most scenarios, it is a clinical diagnosis. It is the complications which need to be looked for. The complications commonly seen in children include acute ITP, aseptic meningitis, and arthritis and arthralgias, although they are more common in adults as compared to children. So, older children or adolescents with parvovirus B19 can have arthritis and arthralgias, and very rarely hemophagocytic lymphohistiocytosis syndrome may develop. Parvovirus B19, potential MCQ, one-liner, it causes non-immune fetal hydrops in pregnant females. Treatment of fifth disease is only supportive. Nothing specific needs to be done. So this finishes fifth disease, and it is apt that we move to the sixth disease. The sixth disease is also called as exantheme subitum or roseola infantum. It is caused by human herpes virus 6, which is the most common pathogen. Rarely, it may also be caused by human herpes virus 7. They all are DNA viruses, or ecovirus 16 or 19. So these are the common causes of sixth disease. The most common age group for sixth disease is 6 months to 3 years. Majority of them are infants. So one of the name is roseola infantum. Rose means, rose is usually, there is a red rose, there is a white rose, there is a yellow rose, but usually the roses are pink. So it is a pink macular rash which is seen, and because it occurs in infants, so originally it was described as roseola infantum. The incubation period for sixth disease is variable, ranges from few days to as long as up to 3 weeks. And the route of transmission again is through the droplet route or respiratory infection. However, it has a low infectivity as compared to others. Others means the others which we have already discussed: measles, rubella, chickenpox, and fifth disease. Now, what are the clinical features of sixth disease? The clinical features again are very characteristic here. Initially, first of all, there will be prodrome. But in prodrome, there will be very high grade fever. High grade fever reaching as high as 41 to 42 degrees Celsius. That can be reached. So high grade fever along with the URI-like symptoms. This prodrome can continue for 3 to 4 days. After that, once prodrome starts to come down and once fever subsides, within 12 hours of fever subsiding, there is onset of rash. So this is very characteristic. Rash comes once fever has gone away. Within 12 hours, the rash will come back. It is like rash is waiting. Fever will go away, 12 hours have passed, now I will appear. The rash is in the form of pink macules. Pink macules. And these pink macules first appear on the trunk, then they spread to limbs and sometimes also to the face. And it is considered to be a non-confluent, they don't merge, non-itchy or non-pruritic rash. Remember, there is another rash which begins on trunk and spreads to the other parts. That is chickenpox, but that is a highly itchy rash. And it also begins as macule, then papule, then vesicle, then crus. Here it is a pink macules which slowly tend to phase. So non-confluent, non-itchy rash which slowly tends to fade in a few days, again few days up to 2 weeks. Usually most of them resolve within 3 to 7 days. So 3 to 7 days, these pink macules tend to disappear. And what is the characteristic feature? The characteristic feature of this rash is presence of Nagayama spots. Nagayama spots. What are Nagayama spots? They are ulcers appearing at the uvulopalato-glossal junction. So if I have to show you the pictures related to this disease, you can have a look here. This is the child with fine pink macular rash present on the body, on the trunk, and then spreading to the face also. And these are the Nagayama spots. Can you see this aphthous ulcer-like lesion? They are ulcers present at the uvulopalato-glossal junction. They are the ones which are called as the so-called Nagayama spots. Again, they tend to resolve with conservative management. Treatment is supportive. No specific therapy is needed in sixth disease. So the key words to remember here is Nagayama spots. Nagayama spots, like presentation in MCQs in super speciality, can be confused with Forsheimer spots. Forsheimer spots are pink macules or pink lesions present on the soft palate in rubella. Here they are ulcers present on the uvulopalato-glossal junction. They are called Nagayama spots and they are feature of sixth disease. So this finishes our major viral illnesses associated with a skin rash.